Okay, our next topic is urinary incontinence. This is very common in particularly older women, and it is associated often with pelvic relaxation, although there may be other causes as well. This is from your local medical journal called the Reader's Digest. New Depend protective underwear. Would you like to be confident? You want to be confident, you wear Depend protective underwear. Did you know that there are more adult diapers sold in the United States than there are children's diapers? This is a very prevalent problem. It is far more prevalent in women than men because women's urethras are only 5 to 6 centimeters long. A male urethra is 16 to 20 millimeters long. This is a $16 billion problem in the United States. Urinary incontinence is one of the main reasons why elderly women are sent to nursing homes because of difficulty in managing them. Here's our case. A 58-year-old woman complains of urinary leakage after exertion. She's 58. What is the average age of menopause? 51 to 52. Most likely this is a postmenopausal woman. Now, she doesn't have to be postmenopausal to have urinary incontinence. She loses urine after exertion. Now, the urine loss occurs after coughing, sneezing, and playing golf. So it is related to activity. What would you think is the most likely explanation? Stress incontinence is the most likely explanation. She underwent menopause 5 years ago, so that was 53. She's not on estrogen therapy, and that may have some impact. On exam, there is urethral detachment. We'll look at how important it is to maintain support of the urethra. And there's a positive Q-tip test. Do you know what that is? I'll show you a picture so you'll never forget it. The first thing that I like to do is to start with a voiding diary or a bladder diary. And what this woman does then is for 3 days, she keeps track of the type and amount of fluid intake. She notes when she urinates, and does she have a strong urge to urinate, and how much did she lose? Small amounts, large amounts? Did she have any accidents? Couldn't make it to the bathroom on time? Again, how much? And was she doing anything? Coughing, sneezing, walking, running. That's going to be very helpful in working up our patient. Let's start with physiology of urinary incontinence. Here we have a picture of the bladder. The pelvic floor is down here. This is the urethra, and this is the bladder with the detrusor muscle around the edges. You can see here is the ureters coming in, and here are the bladder trigone with the orifices. What we want to look at is micturition, which is a nice medical term for peeing. It's basically what it is. And continence is keeping urine in the bladder. If we want to let urine out, we want to contract the bladder and relax the bladder neck and proximal urethra. If we want to maintain urine in the bladder, we want to relax the bladder and contract the bladder neck. And you'll see how this is going to be done by the autonomic nervous system. Let's put some urine in this bladder, shall we? All right, the urine is in the bladder. Let's look at the receptors now. We have cholinergic receptors, which are in the detrusor muscle of the bladder. We have beta-adrenergic receptors, which are in the detrusor of the bladder. And then we have the alpha-adrenergic receptors, which are in the proximal urethra and the bladder neck. How do these fit in? The cholinergic receptors, when stimulated, contract the detrusor muscle. The beta-adrenergic receptors will relax the detrusor muscle. The alpha-adrenergics, when they are stimulated, will contract the bladder neck. If we want to urinate, micturition, the cholinergic fibers are going to be activated. If we want to maintain the urine in the bladder and not let it out, it is a sympathetic, and this is the alpha and the beta adrenergic. One way that you can remember this, at least I find it easy, is the sympathetic fibers are what will come into play when you're scared, when you have the fight and flight reflex, and you want to get away from whatever is the threat, and you run away. You don't want urine coming out when you're running away, so the sympathetic stimulation is going to maintain it in the bladder. The cholinergic fibers come into play when you're in the shower and you're relaxed and the water is spilling over your body. What a perfect time to just let it all out. Micturition. Okay, we're going to look at systometric studies. Systometric studies look at volume-pressure relationships in the bladder. Cystometry is done by, number one, having the patient empty as much as she can out of her bladder, and then we put a catheter in and measure what is left inside. That is called residual volume. Then, leaving the catheter in the bladder, we start filling the bladder retrograde through the urethra with saline. As we put the saline in, we will look to see if there are any uncontrollable bladder contractions. This will show up with rising and falling of the fluid level in here. You keep on going, filling it up, and you instruct the patient, let me know when you feel your bladder is full. We call this the sensation of fullness volume. Then you keep adding saline, and you instruct the patient to tell me when you can't hold any more. We call that the urge to void. So a Foley catheter is placed in, and we put saline in. This is the easy, simple way of assessing. The normal bladder residual volume is 50 to 60 cc's or less. The sensation of fullness, when she recognizes that there is fluid in the bladder, should be around 200 to 225. When she says, I'm going to have to let it go, I can't hold anymore, you better watch out, that should be around 400 to 500 milliliters. So this is physiologic levels. Let's look at how this plays out. We're looking at bladder volume on the x-axis. We're looking at bladder pressure in the y-axis. The urethral pressure, which is what maintains urine in the bladder, as long as the bladder pressure is less than the urethral pressure, you will not lose urine. Let's start filling up the bladder. And you can see that we're filling up increasing volume, and there is nothing coming out because the bladder pressure is below the urethral pressure. You can see at around 400 to 500 milliliters, what happens? The bladder starts to increase the pressure. You get the urge to void, and the pressure goes up. And you say to your bladder, can't quite go. Can you wait for just a little bit? A normal individual can suppress the urge to void, and the pressure will come back down. This is normal cystometry. Okay, classification of urinary incontinence. We can look at it in terms of a variety of different diagnoses. We're going to look at irritative, we're going to look at stress, we're going to look at urge, we're going to look at overflow, and we're going to look at a fistula or a bypass incontinence. So we have irritative, stress, urge, overflow, and bypass. We're going to come back and review this summary at the end of this section. Let's start out with avoiding diarrhea. Okay, let's now look at sensory irritative. This is basically saying, are there anything that can irritate the bladder that makes it want to contract? And there are, such as an infection, a cystitis. There could be a stone in the bladder. There could be a tumor. There could be a foreign body. Involuntary contractions of the bladder. The history is typically urgency frequency dysuria, and this happens any time of day or night. I want you to notice that because we're going to come back to this in a little bit. It does occur at night on exam. If there is an infection, you may have suprapubic tenderness, but the pelvic exam and neurological exam is normal. In other words, there is no cystocele, there's no rectocele, there's no prolapse of the uterus. Neurological exam is when you stimulate around the anus, there is no contractions of the anal sphincter. This assesses the S234 nerve roots. This is the S234 nerve roots, which are innervated by the pudendal nerve. If you stroke on the labia, or if you touch the clitoris, you will get contractions of the anal sphincter. If you have this, this is a normal neurological exam. If you don't see this, you may have problems with innervation, and we'll talk about that under the overflow incontinence. Investigative studies. Let's get a urinalysis. We'll look for white blood cells, red blood cells, or bacteria. If you have an infection on the urinalysis, you will see white cells, bacteria. If you have a foreign body, if you have a tumor, if you have a stone, you may see microscopic hematuria. If the culture is positive, that would be consistent with an infection as well. Management. If you have an infection, appropriate antibiotics based upon what your culture and sensitivity show. If you have microscopic hematuria, you've got to find out what's in the bladder, and we do that with a cystoscopy. This is a cystoscopy, cysto, bladder, oscopy, looking in the bladder. And you can see, looking in to see, is there something in there? It's a light source, fiber optic scope. What do you find in the bladder? Well, you could have an infection. We talked about that. This is your culture. You could have a bladder tumor. You could have a bladder stone. What's this? A foreign body. How would a foreign body get in there? Well, the patient put it in. Different strokes for different folks. It's amazing what the GI people talk about that they get out of the rectum. Coke bottles, little animals, light bulbs. Amazing. Here's a foreign body in the chest. So always think, could there be a foreign body? Look at this in someone's head. I don't know how these got in there. The patient is actually alive. So anyway, think of foreign body, think of bladder stones. All right, and that is our irritative incontinence. Next, we move to genuine stress. And the irritative incontinence is so easy to rule out. How much does it cost for urinalysis? Culture, not a whole lot. Okay, genuine stress incontinence. The etiology, and you need to know this is an anatomic problem. This is loss of support of the bladder neck and the proximal urethra. The history, small amounts of urine, lost in spurts, small amounts. And they occur with coughing, sneezing, running. And the main thing to remember, it does not occur at night. This is the only incontinence that does not occur at night. Genuine stress incontinence. On exam, the neurological exam is normal, normal S234, normal pudendal nerve innervation, and you may have a positive Q-tip test. I'll show you what that's like in just a minute. Here's the problem. The normal relationship between the bladder neck, and the proximal urethra and the pelvic floor is that when a patient coughs and sneezes, the bladder pressure goes up. The urethral pressure goes up exactly the same amount. The differential doesn't change. You cannot cough hard enough to get urine out of the bladder if you have a normal anatomic relationship. Now, what happens when the bladder support is lost? The bladder neck and the proximal urethra drop below the pelvic floor. Now when she coughs and sneezes, the bladder pressure goes up. What happens to urethral pressure? It doesn't change at all because there is no transmission to the proximal urethra. Once the bladder pressure exceeds the urethral pressure, what will happen? Urine comes out. That is the main problem with the stress incontinence. It is an anatomic problem with loss of support of the bladder, neck, and proximal urethra. So when you increase intra-abdominal pressure, it is transmitted to the bladder, but not to the urethra. Does the bladder ever contract? It never contracts. It never contracts. And that's the difference with this genuine stress incontinence. Okay, here's our Q-tip test. The bladder is in yellow. This is the pubic symphysis, the perineum, and what we have done is to put a lubricated cotton tip applicator or Q-tip into the urethra. It should normally be sticking straight out. Now, then we have the patient increase intra-abdominal pressure, strain, Valsalva. If there is loss of support of the bladder, what will happen? It's going to drop down like this. But notice what happens to the urethra then. The urethra changes its angle, and the Q-tip will go up. It is this change in angle between the urethra and the Q-tip when she crosses the strains that is an indicator of what's happening internally. We have loss of support of the bladder, and the urethra will then change its angle, and the Q-tip goes up. This will be a positive Q-tip test. Okay, investigative studies for genuine stress incontinence. The urinalysis, as we've said, is going to be normal. No red cells, white cells, no bacteria. Culture is negative. The main thing is detrusor contractions are absent. The bladder never contracts. And symptom-wise, remember, no loss of urine at night, unless she coughs or sneezes at night. The management could be either medical or surgical. Medical management would be Kegel exercises. We already talked about that. If she's postmenopausal, hormone replacement therapy, estrogen can strengthen the tone of the pelvic structures. And if it is severe, surgical management is a urethropexy. Urethro is the urethra, and pexy is to support and elevate the proximal urethra and bladder neck. The cystometry is normal. There is a normal voiding residual. There is a normal sensation of fullness, there's a normal urge to void, and you can suppress. The procedure which is done historically was to elevate the proximal urethra and bladder neck above the pelvic floor. This is a pelvic floor, this dark line here. And you can see by a series of sutures, you elevate gradually so the proximal urethra and the bladder neck is now above the pelvic floor, whereas it used to be down below. The procedures that were described were the Birch procedure or the MMK. And I wouldn't even remember this, but at least let me mention it to you. It's a Marshall-Marchetti-Krantz. If you see MMK, at least you know what we're talking about. This is what historically was done. This is the MMK. The bladder is here, the urethra is here, and what you do is you suture the area which is on the proximal urethra to the pubic bone. The Birch procedure is very similar. A more recent procedure is called the tension-free vaginal tape procedure. This is a less invasive. You do a percutaneous incision, and you place a tape around the urethra. Now, you don't lift up the urethra. What it does, it provides a resistant platform against intra-abdominal pressure. So when you increase intra-abdominal pressure, it doesn't drop down. If you would hold this up all the time, you could get erosion into the urethra, and we don't want that. This is a tension-free, so there's no tension on it. This is another way of doing it, tension-free vaginal tape. You can also support it by doing the transobturator tape, by attaching it to the obturator muscles here. This looks kind of gross, but this is how you do it. You have this instrument which does a percutaneous incision, and it comes down around the urethra, and it comes back on the other side. So this is the tension-free vaginal tape procedure. And it's used for genuine stress incontinence. Now we have the motor urge incontinence, also known as the hypertonic. This is sometimes called the itty-bitty bladder syndrome. History: large amounts of urine lost without warning. Involuntary, without warning, day and night, and there is a sense of urgency. When she's got to go, she's got to go. This woman is governed by her bladder wherever she goes. The first thing she does wherever she goes is to look, where is the nearest bathroom? Because when she's got to go and get out of there pronto. If she doesn't, what's going to happen? She's going to wet herself. Investigative studies: urinalysis, no white cells, no red cells, no bacteria. Culture is negative. But the main thing to remember is detrusor contractions are present. This is the only one of the incontinences in which there are involuntary detrusor contractions. The only one. Now, what was the arm of the autonomic nervous system that causes contractions of the bladder? The cholinergic. So we want to suppress the cholinergic, so we will use anticholinergics. Now, interestingly, nonsteroidal anti-inflammatories, tricyclic antidepressants can also be used, but the mainstay is anticholinergics. So you want to block those cholinergic receptors. This is the profile that we'll see on cystometry. Notice that she gets a sense of fullness, very low volume, and the urge to void at about 200 milliliters. So she seems like she wants to go all the time. She gets this increase in bladder pressure, and she says, bladder, can you wait just a little bit? I can't go right now. And her bladder says, too bad, so sad. And what happens? It gets wet. And here she is in traffic. I gotta go now. So what do you do when you gotta go? And you can't control it. An overactive bladder can be an accident waiting to happen. This is so clever. Look at this here. She's running as fast as she can. Can't get there in time. Accidents can happen. So what do? Oxybutynin. This is an extended release tablet of oxybutynin, which is an anticholinergic. Now this is the oral tablets. You can do it with transcutaneous patches as well. Do you worry about getting to the bathroom on time? I'm glad I asked my doctor about tolterodine, anticholinergic. Now she's going to get some control. This is a big issue, big problem. Okay, the next topic is overflow incontinence. Now the previous one, remember, was a hypertonic bladder. This is a hypotonic bladder. This is also called a neurogenic bladder. It doesn't want to contract. It doesn't know that it's even full. History: small amounts of urine lost intermittently day and night. Now the bladder never contracts. The bladder never contracts, but it loses urine because the intravesical pressure exceeds the urethral pressure. On exam, neurological exam is abnormal. She does not have the innervation of the S234. This could be either a medication-induced problem, and we see this quite frequently after a epidural analgesia or anesthesia during labor. And the bladder doesn't even know it's full. Or this could be a chronic problem, neurological problem, such as multiple sclerosis, which is more common in women than men. Investigative studies. The main thing to remember here is the residual volume is huge. Here we have a patient who empties as much as she can, and she's got 500, 600, 800 milliliters of urine in her bladder. She doesn't even know it. And notice detrusor contractions are absent. This bladder doesn't want to contract. It is a neurogenic bladder. So, which arm of the nervous system, of the autonomic nervous system, do we want to stimulate? The cholinergic. So we will use cholinergics. Now, if she has multiple sclerosis, and this is going to be a chronic lifetime problem, she may need to do intermittent self-catheterizations every 6 hours. But cholinergics are what we would use if it is a limited medication-induced problem. Notice what happens here. We start increasing the bladder volume, and the bladder pressure hardly goes up at all. 400, 500, 600, and then maybe it starts to gradually go up, you can see here. Once the pressure in the bladder exceeds urethral pressure, what will happen? Small amount of urine comes out. Does the bladder ever contract? No. As soon as the volume that has been lost is enough to lower the intravesical pressure below the urethral pressure, the urine stops. But does the bladder ever empty? No. Never empties. This is hypotonic. This is the neurogenic bladder. This is the detrusor atony. And here you can see is normal volume of the bladder, and this is an overstretched, overdistended bladder with a large residual volume. This is impaired sensation, overflow, incontinence. So, bethanocol is a cholinergic, which can stimulate the cholinergic fibers in the detrusor muscle. When nature won't, urocholine will. And we'll use this often in postpartum patients who can't empty. All right, so that is the overflow incontinence. Now we come to the bypass or fistula. The reason we call it bypass is because the urethral sphincter is bypassed. The urine does not go through the urethral sphincter. In all of these others, it does. But in this one, it is bypassed and it goes through a fistula from someplace in the urinary tract. Vesicovaginal fistula would be a common one. The history, notice it is continual urine loss, not intermittent. It is continual loss, day and night, and it is often associated with either radical pelvic surgery, such as a radical hysterectomy, or an anterior resection of the colon because of colon cancer, or radiation therapy, where you have devitalization of the blood supply, and we have a fistula. The investigative studies, if you would do an intravenous pyelogram, you would see dye leaking out wherever the fistula is. If this was a vesicovaginal fistula, intravenous methylene blue dye, which will then go into the urine, will leak out into the vaginal tampon with a vesicovaginal fistula. Medical or surgical management. There's surgical repair. You're going to have to fix this surgically. This is a X-ray, and the distended large area here is the bladder. And you can see the radio-opaque dye in the bladder. Here you can see is radio-opaque dye in the vagina. How would it get into the vagina? Through a vesicovaginal fistula, which is right here. You can hardly see it. It is very fine, very small, but you can pick that up on the intravenous pyelogram. This is surgical repair. This is through a vaginal approach, and you basically cut out the fistula and you close the bladder in 2 layers. You can also do a transabdominal approach, and you actually open up the bladder like this. The bladder is very forgiving. You close it together. You have to leave a catheter in for a few weeks in order to allow the healing to occur, but should be done very nicely and usually no long-term problems. Now, this vesicovaginal fistula occurs in many developing countries where young girls get pregnant, often married off at very young ages. They have big babies, they have obstructed labor, you have pressure against the bladder and the urethra for hours and hours, causes denervation, ischemia, and then you have a vesicovaginal fistula. This is very common in Nigeria, in Ethiopia, in Sudan. And here's in Addis Ababa Fistula Hospital, over 25,000 young women have had their fistulas repaired. And this becomes a social problem because she's leaking urine all the time. It becomes smelly. Nobody wants to have any association with her. And she becomes a social outcast. Fistula repair. All right, let's summarize what we've just said. The first thing we want to do with urinary incontinence is to get a voiding diary, document the urine loss, the amount of urine loss, the time, the activity. And then we come into our differential diagnosis: irritative, stress, urge, overflow, and bypass. The main thing to remember with an irritative is their urinalysis, red cells, white cells, bacteria, and CS is culture sensitivity. If we have white cells, bacteria, and a positive culture, we're going to treat with antibiotics. If there is microscopic hematuria, then you need to find out, is there a foreign body? Is there a bladder tumor? Is there a bladder stone? Cystoscopy. This is going to be surgical removal or repair. Stress incontinence is probably the most common. The main thing to remember is that you do not have loss of urine at night. It never occurs at night. It's the only one which doesn't occur at night. Urge incontinence occurs at night. Overflow occurs at night. Bypass occurs at night. This is the only one that doesn't occur at night. Medical management, either Kegel's exercises, we talked about that. Estrogen replacement therapy, if it is severe, you need to have elevation of the proximal urethra, the bladder neck, urethropexy. Okay, urge incontinence. The main thing to remember here, involuntary bladder contractions. It is the only one that has involuntary bladder contractions. You want to suppress those with anticholinergics, or you can also use nonsteroidal anti-inflammatories. This is seen more commonly in older women, and particularly postmenopausal women. Urge incontinence, itty-bitty bladder, can't make it to the bathroom on time. Overflow. The main thing to remember here is a very high residual volume, 500, 600, 700 cc's. It's the only one that has a high residual volume. This is a neurogenic bladder. We're going to stimulate the detrusor muscle with cholinergics. Alpha adrenergic blockers are going to relax the bladder neck. If it is a chronic neurological problem, you may need to do intermittent catheterization. Then we have bypass or fistula. The only thing to remember here is continual leakage. It's the only one that has continual leakage is the bypass. This is not medical management. This is surgical management. The diagnosis, intravenous pyelogram and methylene blue dye, which is put into the blood, and it is then filtered into the urine, and it will show us where the fistula is. That is the end of urinary incontinence.